Hello. I think the comment about measuring social support is really important, especially as we provide multidisciplinary teams. And I'm excited to be here today to talk about a community-based intervention. So again, my name is Mary Guyton. I'm a registered nurse with the Toronto Community Hep C program. Thank you for inviting me here today to speak with you about our ongoing study of adherence during Hep C treatment for clients of a community-based Hep C program in Toronto. I have nothing to disclose. The Toronto Community Hep C program was created in 2006. The program sought to address gaps in care that existed, particularly for people who use drugs and/or alcohol. Unfortunately, these barriers continue to exist today. Over the years, the program has evolved in response to the new treatment landscape, and it will continue to evolve. Our current model is a multidisciplinary healthcare team providing social and practical supports. Treatment is delivered by primary care providers with a consulting infectious disease specialist. Clients can also receive mental health counseling and case management supports. In addition to one-on-one appointments with clinicians, clients can attend psychoeducational groups. Our groups anchor the program and function as both a source of information and mutual support, allowing members to learn from each other and create a social network. Our introductory groups focus on Hep C education while facilitating treatment workup. If eligible, clients can transition into our weekly treatment group. A third group, Continuing Care, is open to clients who are post-treatment or not eligible for treatment as a means to stay connected and provide aftercare support during weekly drop-in sessions. The program is based on the principles of harm reduction and community development. An essential component of the program is to have former or current clients in both advisory and service delivery roles. To give you some background on our research, we began this study in June of 2015 to evaluate treatment for marginalized people who use drugs receiving DAAs. We sought to add to the body of knowledge as there was little data available about this in the real world. In particular, there was little data about adherence in this population, which, as we know, is a major predictor of treatment success. Our aim was to evaluate patterns and factors associated with adherence among people who use drugs and who are receiving Hep C treatment through our program. Our eligibility. We enrolled anyone from our program who was willing, able to participate in English, and who was initiating DAA treatment at one of our program locations. Clients completed weekly self-report medication adherence questionnaires, and pre- and post-treatment questionnaires were administered by our research coordinator, who was not part of the clinical care team. The adherence questionnaires were designed and administered based on best practice for measuring medication adherence. This includes neutral assessment language, a short time frame for completing questionnaires, and separation of adherence reporting from the healthcare provider relationship. Any missing data was counted as a missed dose. Just a little overview of our demographics, which are quite representative of our overall program demographics. You can see that most of our clients are men living on very low income, with nearly 1 in 3 reporting unstable housing at baseline. The majority have a history of injection drug use, and 1 in 10 reported injecting in the month prior to treatment initiation. Nearly a third identify as active drug users by other means, which is a more typical pattern for our program and for Toronto. Of note, 45% of participants completed elementary or less of formal education, 87% have a history of incarceration, and 31% had had a negative experience with healthcare in the last year. Most of our participants were treatment naive and genotype 1. 1/3 had a fibrosis level of 4. The majority received soft liposphere. Just over a quarter of participants were on treatment for 8 weeks. 58% were on treatment for 12 weeks, and 15% for 24 weeks. So looking at our results, 38% of participants had 1 or more missed doses, with the average number of missed doses per treatment course at 1.72. At the time of analysis, 66 participants had reached the 12-week post-treatment with an intention to treat proportion of 85%. Of the 10 who did not achieve an intention to treat SVR, 3 were lost to follow-up, 1 did not complete treatment, 3 died prior to measurement of SVR, and 3 were treatment non-responders. In a multivariable analysis of factors independently associated with weeks having missed doses, included duration of treatment and moderate to heavy alcohol use. Variables that were not associated were gender, education level, mental health indicators, and a history of incarceration. The primary outcomes from the study was whether each treatment week on the study contained one or more missed doses. Missing outcome data for a given week, result from a missed appointment, was coded as having at least one missed dose. So our limitations, as I discussed with our program model earlier, it's designed to establish a high level of healthcare engagement and social support, which may not be present in other healthcare settings and limits generalizability. The self-report adherence may also be a limitation. However, recall bias was minimized by using a short turnaround time. In addition, the harm reduction orientation of the program model, which fosters openness and a lack of judgment about substance use, likely also supported greater honesty about non-adherence. Although our sample size was relatively small, we believe this was the largest real-world study to address DAAs among marginalized people who use drugs and where OST was not a requirement for treatment or study inclusion. Additionally, our analysis was conducted to treat each week as an independent event, thereby maximizing statistical power to detect factors associated with a week with a missed dose. So in summary, this study provides insight into the real-world Hep C treatment adherence patterns of marginalized people who use drugs, as well as some of the factors associated with adherence. And we conclude that despite complex social challenges and high rates of substance use, adherent rates are higher than what we might anticipate. The study demonstrates that a community-based and supportive model of Hep C treatment can support strong adherence and produce positive virologic outcomes. So if you'd like more information about our program, various components have been evaluated and published over the years, and here's a list of our publications. And then I'd just like to thank my partners in the work, many of who are in the room here. And I'm happy to answer questions. I'm new to our research team here, so any methodological questions, I'll refer you to our PI, Jeff Powis, whose email is on the slide, but I'm happy to answer any questions about our program model.
Thank you, Mary. So we do have time for some questions, but maybe I'll just follow up on your observation that 87% had a history of incarceration in this group. And I think that's, and also to follow up on Mark's talk, in Canada, our approach to incarcerating people who use drugs is highly problematic in the eyes of many people. And I think once people are inside prison, we're way behind groups like Jason. Jason has some students presenting on the work done in prisons in Australia, and in Canada we're way behind. So I'm glad you're keeping track of that. I don't know if you have any comments to make about what that history of incarceration meant to the people that you see in your community-based practice.
I believe that the history of incarceration, I mean, just shapes so much of what they bring to the healthcare experience and to their daily lives in terms of stigma. So I think it can't be understated how impactful that is.
Yeah, thank you. Any other questions? Yes, Sam?
Hello?
Hi.
Okay. In the interferon era, we used to insist on that observation, one of your main findings, that alcohol plays a role in poor compliance. And we used to insist on 6 months of abstinence. And now we think DAA era, the treatment's a lot easier to tolerate, et cetera. So we're trying to have a much smaller period, a month or two. But we still like to do that for exactly that reason. Do you guys, you have a different population because my population is not actively injecting, or the vast majority are not, or actively using drugs. But do you try to make them go through a rehab program or do something or be abstinent for a month or something?
Absolutely not. We think that that's definitely a barrier to engagement. And just to comment on the findings about alcohol use, I think it's a really complicated finding. We're really trying to tease out what that means, and we don't really believe that impacted the SVR rates. It is connected with a missed dose, but the missed dose were so small, 1.7, that. But absolutely, we do not have any abstinence requirements in our program, and we think that that's a really important part of the work for us.
Thank you. Last comment, question to Jason.
It's Jason Grebley from UNSW Sydney. I just wanted to comment on Sam's comment. I think we need to be really cautious about making decisions like that. There's no data yet in terms of in the real world about whether ongoing injecting drug use or ongoing alcohol use. Some preliminary data here that showed maybe it had an effect on adherence, but not on overall SVR. Absolutely. I think we need to continue to do more real world studies. I think you did a fantastic job, and I'm always so impressed with the work that you guys are doing there. But we need evidence in real world populations around the impact of drug use and alcohol. In fact, the EASL recommendations have sort of just been, there's been an iteration in terms of re-emphasizing that all people who inject drugs should be provided universal access for Hep C therapy, irrespective of ongoing drug or alcohol use. So I just wanted to make that comment, so thank you.